Hello, my name is Paul Vespa. I'm from UCLA, and I'm going to talk about status epilepticus facing the emergency today. My conflicts of interest are on this slide. Um, our agenda for today is to talk about the time urgency for the treatment of status epilepticus and show you some lessons from recent clinical trials, talk about the use of continuous EEG monitoring, and show you some options for the treatment of refractory status epilepticus. Time is urgent in status epilepticus. Status epilepticus is defined as seizures lasting greater than 5 minutes. Status epilepticus is a brain emergency and treatment is needed. And if the status epilepticus goes on too long, there is a risk of causing neuronal injury. Timing is very important, and this study shows us that there is often a delay to treatment of status epilepticus, and that delay can be associated with poor outcomes. And oftentimes there's an improper dose or drug or sequence of drugs that occur during the treatment of status epilepticus. So rapid treatment in the pre-hospital setting is supported by level 1 evidence in clinical trials. And I'm going to talk to you about the San Francisco pre-hospital trial and then the Rampart trial. Both of these trials talk about the use of benzodiazepines as a treatment in the pre-hospital setting. This is the San Francisco Emergency Pre-Hospital Study. This was a randomized controlled study of benzodiazepines given by paramedics in the emergency ambulance. Seizures greater than 5 minutes were treated, or if they were repeated seizures, then they were thought to be in status epilepticus. They were either given diazepam or lorazepam, and then or placebo in those doses. And lorazepam given as IV push, 2 milligrams IV push, really had the best chances of stopping a status epilepticus, and placebo had a much lower risk, much lower incidence of stopping the status epilepticus and a higher incidence of adverse events. The Rampart study was done in 2012, and this was a randomized controlled trial of lorazepam IV intravenously versus midazolam given intramuscularly. And this is the study, a similar seizing for greater than 5 minutes, 4 milligrams of IV lorazepam versus 10 milligrams of IM lorazepam. In children, they used smaller doses than adults. You can see the distribution of patients. And it turned out that the intramuscular midazolam was more effective in stopping a greater percentage of patients with seizures than the lorazepam, but both were very good, as shown in this slide. It turns out that that giving IM midazolam resulted in getting the patient the drug very quickly. So time from opening the box in which the kit came for the medication to the time of active treatment was much shorter with an IM injection than the IV injection. And the time to stopping seizures was also shorter with midazolam. And the time from active treatment to cessation of convulsions was shorter with IV lorazepam. So that study demonstrated that either IM or IV could be used. IM midazolam or IV lorazepam could be used. This is the VA cooperative study, which is a little bit older. This has a treatment of patients in the emergency room. Now we're moving from pre-hospital to emergency room. And these were the doses and different drugs given. And they tried to control status epilepticus both by EEG and clinically within 60 minutes. What they showed here was that lorazepam was the best drug in stopping status epilepticus. Over 65% or so of about 65% of patients were controlled with lorazepam, and less were controlled with the other medications. And so lorazepam is the recommended medication to be given by intravenous in the emergency room. Then this is the most recent study. This is called the ESET trial, or the Established Status Epilepticus trial. And this was a randomized controlled study of 3 different medications that were given as IV bolus medication after the benzodiazepines failed. So everyone got benzodiazepines first, If they didn't have control of status epilepticus, they went on to get either fosphenytoin, valproic acid, or levetiracetam in these doses. This is the number of patients per study. And they looked for control of status epilepticus. And what they found is that each of these medications controlled status epilepticus between 45 and 50% of the time, and you can see the distribution of control, and they all overlapped with each other. No single drug was any better than any other drug in controlling status epilepticus. The side effects profile here and outcomes are shown in this slide. Again, there was really no specific drug which performed better than the others overall, and that was the conclusion of the study. There are guidelines for the treatment of status epilepticus from the Neurocritical Care Society, as outlined in this 2012 paper. And these guidelines really talk about the critical care treatments that should be done, the time urgency of it, and what the goals are of the treatment. And of note, giving initial benzodiazepine very early on is important. Urgent control of the status epilepticus is important. And then doing continuous EEG or getting some type of EEG done within 1 hour is also important if the patient is not waking up or not improving from the status epilepticus. There are now rapid EEG systems that are becoming on the market. The idea is to get the EEG done within 1 hour. There are several different systems available. We published this trial just recently in Critical Care Medicine called the DECIDE trial using this device, which is like a headband device, getting the patient onto EEG very rapidly. And we were able to get the patients onto EEG very quickly, within a median of about 5 to 10 minutes after the decision to get the monitoring on board. And this device is very rapid to use and was helpful in improving our overall confidence in our diagnosis of status epilepticus and improving our confidence in our treatment plan. And the overall complications were pretty minimal, and the overall satisfaction with ease of use was pretty good. For refractory status epilepticus, there are two possible approaches. So now, after you've done the benzodiazepine and you've done a loading of one of these medications, what can you do next? Well, you can give more medication by bolus, or you can go to continuous infusions. And there are different medications now that have been published with the use of continuous infusion, and some of the doses are shown there. Treatment of prolonged refractory status epilepticus can be challenging, but in this particular study, they showed that some patients can have good outcomes. And even though the mortality is high, there can be good outcomes. And so there's enthusiasm for continuing to treat these patients. In summary, I just want to say that status epilepticus is an emergency. Time is brain. There should be a focus on rapid treatment to stop seizures. Rapid EEG should be attempted to try to make sure the seizure is actually stopped. If the patient has refractory status epilepticus, one should consider continuous infusions of anti-seizure medications in order to get the seizures stopped. And there are good publications outlining how to do that. No big randomized controlled trials yet, but some reasonable level 3 evidence. And good outcomes are possible even for refractory status epilepticus. I thank you for your attention, and this ends the presentation.